Okay, I think we can get started just to respect everyone's time. So I'm pleased today to welcome you to the Ontario Regional Roundtable on Flexible Models of Care for Opiate Use Disorder in Ontario. So to start us off in a good way, I would like to acknowledge with gratitude that I'm joining you from the traditional lands of the Huron-Wendat, the Mississaugas of the Credit, and the Seneca, which is also known as Toronto. But this is a provincial session, so I'd like to acknowledge that people are joining you from across what is colonially known as Ontario. And this is especially important to reflect on, as we know that Indigenous people are disproportionately affected by the opiate crisis. So I would like to pause for a moment so that you can take a moment to acknowledge where you are joining from today. And if you like, I would invite you to put in the chat where you're joining from today. Okay, thanks everyone. So just to introduce myself, I'm Dr. Nikki Bozinoff. I'm a family physician practicing in addiction medicine out of the Center for Addiction and Mental Health in Toronto, also a clinician scientist, and I also consult to a remote First Nation community in Ontario. I was also a study physician for this trial, and so I'm pleased to tell you about it today. We also have an amazing lineup of speakers, which I'm sure you're all excited to hear from. Today's session is primarily to try to learn about the findings of the trial and hopefully have a discussion about flexible models of care. This webinar is part of a suite of knowledge translation activities that are going on as part of this trial. And there is another one, I believe, March 9th. We've also had some knowledge translation activities with people with lived and living experience, which has been really interesting. So I will start with a brief presentation. I'll keep it really high level about the OPTIMA trial. And then we will have a panel discussion, which is really the meat of why you came today. Housekeeping items, please keep your camera and microphone off during the session. The session is being recorded. You can enter any questions in the chat, and we have a moderator, Maddie, who will be noting those. We'll have some time at the end of the panel to get to your questions. Also, there's a pre and post evaluation survey, and you can be entered into a draw for $50 if you complete those. So I encourage you to give us some feedback about this session. Just quickly checking the chat. Okay, people are letting us know where they are checking in from. Thank you. So let's get started. We did this. We talked about the agenda. So our objectives today, again, are to share information about the OPTIMA study and its findings, to discuss the clinical practical application of the study findings, and to discuss opportunities to use flexible models of care. I don't have any conflicts of interest related to this trial. So to set the stage, as you know, opiate agonist therapy, that's buprenorphine, methadone, and long-acting morphine remain the standard of care for opiate use disorder, including prescription type opiate use disorder. However, there are multiple barriers to access and retention in opiate agonist therapy, including strict supervision. So anyone who is a clinician knows that one of the major barriers that patients state to not wanting to remain on treatment is needing to go to the pharmacy regularly. It really impacts their quality of life. The safety of buprenorphine naloxone allows for a more flexible model of care, meaning there's a lower risk of respiratory depression, and so we feel more comfortable giving this medicine to take home early, but it's poorly studied in the context of prescription type opiate use disorder. So this is a review of OPTIMA. Our goal was to compare the effectiveness of buprenorphine naloxone to methadone models of care in a real-life clinical practice setting in individuals with prescription type opiate use disorder. So this was a pragmatic trial, meaning that these were real clinics, and the way that we saw patients and the way that we the way that we administered the trial was similar to what happens in day-to-day practice. It was a 2-arm, open-label, multi-center, pragmatic randomized control trial. The primary outcome assessed the non-inferiority of buprenorphine naloxone flexible take-home dosing to methadone standard models of care to suppress opiate use in people with prescription-type opiate use disorder. They had study visits every 2 weeks, which included urine drug screening for the 24 weeks of the intervention period. These are the locations of where the study took place. And this just gives you an overview of the study schematic. So you can see that in the buprenorphine arm, which is a flexible dosing arm, they had a traditional induction with 4 milligrams up to a total of 12 milligrams on the first day. And then the dosing followed usual clinical practice up to a maximum of 24 milligrams. And then what was interesting and what the intervention was in this study was that you could have up to a week of carries 2 weeks after initiation and up to 2 weeks of carries 4 weeks after initiation. And then methadone here was dosed essentially similarly to how we practice day to day. That is, there was supervised ingestion of methadone for the first 2 months with the option of progressive take-home dosing after 2 or 3 months, depending on provincial guidelines. So these are the eligibility criteria. So because it's a pragmatic trial, we tried to include a broad section of the population. So adults 18 to 64, they had to be diagnosed with opiate use disorder related to prescription type opiates. So that could include fentanyl. They had to be open to being randomized to either buprenorphine or methadone. They were excluded if they had unstable psychiatric or medical condition that would preclude safe participation, but generally comorbidities were not an exclusion criteria. Pain requiring opioids, heroin use as the most frequent opioid in the past 30 days, enrolled in other OAT in the last 30 days, a history of severe adverse reactions, and then if they were pregnant or breastfeeding. So what were the findings? So in total, 272 participants were enrolled in the trial. The average age was 39, and most of the participants were men. You can see that the mean dose for both medications, was within the range that we think is kind of the optimal dose for these medicines, although methadone, on the lower end of that. If you look at the percentage of people who received take-home doses, you can see that the trial did what it set out to do. So most of the people in the buprenorphine naloxone arm did get take-home doses, and they were initiated quite quickly, meaning that the study physicians adhered to the study protocol. And this is in contrast to methadone, which were following the traditional guidelines, and so people didn't get take-home doses until quite later on. And what's interesting is that in this trial, we did allow crossover. So some people switched from buprenorphine and some people switched from methadone. And we'll talk about this a bit later, but more people in the buprenorphine arm switched compared with in the methadone arm. To continue the findings, so this is the primary outcome, the average proportion of opiate-free urine, 24% in the buprenorphine naloxone arm and 18.5% in the methadone arm. So you can see that the results were comparable in both arms. And then this looks at retention. So the percent retention in the assigned OAT, as you can see, as I discussed before, there were less people retained in the buprenorphine arm compared with the methadone arm. And this is a finding that's been reproduced across the literature, so it's not a new finding. Methadone is associated with increased retention and treatment. However, when you looked at retention in any OAT, that is when you allowed people essentially to cross over from buprenorphine to naloxone or methadone to buprenorphine, there was a similar rate of retention. And then the most common adverse events for both medicines were withdrawal symptoms, overdose, and hypogonadism, and this was similar in both groups. These are ancillary studies associated with the trial, so I won't go through them all, but if you're interested, you can certainly read more. But what you can see is that both arms were associated with a good quality of life. Both arms were associated with reductions in cravings. Both arms were associated with reductions in depressive symptoms. Patients were generally satisfied with both medications. Both medicines worked with respect to pain control, although methadone slightly more. And the sexual function findings were interesting. There was a decrease in sexual functioning with methadone, which we know, but especially in women. So implications for practice. This is the main finding of the study. Compared with supervised methadone, buprenorphine, flexible buprenorphine models of care was safe. It was non-inferior in suppressing opioid use, and it was associated with decreased retention, as I discussed with respect to assigned OAT, but similar retention when we considered any retention in any opiate agonist therapy. And so the implications are that we could consider early take-home dosing when it's clinically indicated, meaning people could get take-home doses as soon as 2 weeks, a full week of carries, and consider step strategies for the clinical management of prescription opiate use disorder, meaning we need to have quite low barrier to be able to switch someone from buprenorphine naloxone to methadone and vice versa if they're not doing well on that treatment. But reaching these optimal outcomes might be difficult in the real world. We need to have proactive discussions between clinicians and clients with OUD on how to make their treatment more patient-centered and base it on their individual needs. And we need more research on adjunct interventions, alternative models of care, and other strategies to improve outcomes. Oops. I want to thank the study PIs across the country, as well as the node managers and all the data safety monitoring board members, everyone who helped out with this research. This was the first national clinical trial for CRISM, so hopefully there will be more Canada relevant research to come. I want to thank you, and I would now be happy to answer any questions if you have them about OPTIMA specifically. Otherwise, you can save them to the end and we can move straight to our panel. Okay, not seeing any questions. So I'd like now to move to the panel. If I can ask the panelists to each introduce themselves, that would be amazing, and share what lens they bring to this discussion today. I will call on maybe Claire first.
Hi, folks. I'm Claire Bodkin. I'm a family doctor. I work in Hamilton and provide OAT in an inpatient setting as well as in an outpatient setting. My outpatient clinic primarily prescribe OAT in conjunction with safer opioid supply. And then I also am a rural locum up in a community called Gitchnamay-Coostabinanawig, which is a fly-in community in northwestern Ontario, and locum coverage in other communities, and that's more full scope family practice.
Thank you so much. Mae Katt.
Good morning, everyone. Nice to see you on. Hi, Whip. So I'm a nurse practitioner. I'm actually located right now in the traditional territory of the Fort William First Nation. I'm from Temagami, which is just north of North Bay. For the last, since 2011, I've been working in mostly doing Suboxone treatment. Again, I call it Suboxone because we only use brand name in the remote northern communities. And as a nurse practitioner, we received prescribing authority for controlled drugs in 2017. Before that, we worked in partnership with physicians to create a network of community-based programs in remote northern communities. 49 First Nations is the territory where I work. So.
Thank you so much. Whip.
Hi, my name is Wiplove Lamba. I'm a psychiatrist by training, but I do a lot of addiction medicine in the hospital setting. And for a subset of patients, I'll see the transition out into the community for them as well. And that's the lens that I'm bringing, I think, for this talk.
Thank you so much. And Mark.
I'm a community-based pharmacist in Ottawa. We operate 5 locations in our kind of inner city, a little bit of rural Ontario as well. 4 in Ottawa area, 1 in Cornwall. They're community-based pharmacies, but they're dedicated to complex mental health and substance misuse. We partner with Recovery Care, the outpatient clinic service next to us, as well at all of the locations. I serve on overdose task force with the city of Ottawa and do a bunch of provincial work around overdose prevention as well.
Amazing. So welcome to all of our panelists. So I'd like to start off with the first section for our panel. So one of the key findings of the OPTIMA trial was that take-home buprenorphine naloxone was non-inferior to traditional treatment with methadone, and that flexible models of care improve treatment outcomes. So I'd like to ask the panelists, how do you see flexibility impacting your practice, and where can we go from here?
Right, maybe I could just start with that. It's a bit tough because it's hard to generalize flexibility just sort of based on the trial, given the diverse clinical practices we do as in the outpatient setting, and it was very specific what the OPTIMA trial looked at. In terms of flexibility from my end, it's very hard when you rigidly follow guidelines, right? So whether it's the old methadone guidelines, the Ontario buprenorphine guidelines, which were basically transposed almost from the methadone ones, because a lot of times you'll have patients that have an opioid use disorder, they'll have maybe a chronic pain condition, they might have an acute pain condition, and they may be going to an environment that doesn't allow for daily observed dosing. And historically, with the heavily regulated methadone and the audits that were being done, people were quite scared to go outside of those in any way, even if you felt that the patient would potentially benefit from more flexible dosing. So from my end, I think it's just it's a bit more humane and compassionate when you have somebody in hospital for an acute injury. They're on high dose opiates to manage their acute pain. We all know that if you have an opiate use disorder, your requirements are going to be higher than if you don't, for an acute pain issue. And so having that flexibility to personalize it for the patient based on their comorbid medical conditions, based on their pain condition, based on their mobility, based on their home environment is incredibly important. And the way that I get around it is just around having colleagues that I can consult with and talk to make that happen. It is a bit hard to talk about this trial just because of it's so specific and focused, and I think there was a lot of pressure to get something out there that really leverages the national network that's been created, and I'm not, so but I'll leave it at that for now. But it's hard to generalize the trial to current practice. But I believe in flexibility.
Yeah. Thank you so much, Wip. Yeah, I think that what Wip is getting at is that since the trial was started, there's been a push for flexibility in methadone models of care also, which I think is great. And so I think if we can use this evidence to build on also what came out of the COVID-19 pandemic, we will be really implementing flexibility. Does anyone else have a case to share or anything they want to share about flexibility? Yeah, Mae Katt.
Yeah, I think with a lot of the flexibility need came from location geography. So in the northern remote and rural communities, again, we don't have the services. We didn't have RAM clinics at the time. We had very few prescribers. So we had to create models that built in flexibility. We were working with unregulated care providers at the time. The nurses weren't allowed to work with Suboxone, which is a little bit curious. So we had to go sort of outside of the existing health system to create these models of program delivery. So we have a number, over 25, again, remote communities that are delivering Suboxone programs. And it is brand name because we do a model called low dose to discontinuation. Actually, there is an article on that has Benedict Fisher. I think I'm the first author on that article, and we showed that you can get good retention by using flexible models. Our communities they range in size from 3,000 people, still no pharmacies there. Where we run into difficulties, and maybe Mark would be interested in this, is when community members come to urban hubs for medical appointments or for treatment, the pharmacies actually insist on direct observed therapy. And there's a couple of reasons for that. I think you get an extra $10 a day every time you give a Suboxone tablet under the tongue. But they also insist on ancillary medications like Wellbutrin to be given out every day, and clonidine, which makes no sense to me as a nurse practitioner because I don't bill non-insured health benefits, and that's their third-party drug coverage. And the other thing is, you know, this racism that exists with Indigenous clients. I've heard many stories that I couldn't believe as a nurse practitioner. Spoke to the pharmacist and got the same treatment, unfortunately. You know, and again, not sure why that's there. It shouldn't be. You know, we talk about stigmatizing our clients just because they're drug users, but they should not be because they're Indigenous as well. So again, lots of issues, but flexibility is required when they're in a city because number one, they don't have cars. They fly here, they take taxis, they don't have a lot of money. But again, the only way you can prevent them from the racism they face is to give them 14-day carries when they're in a city. Again, 14 days of 4 milligram is not a lot of drug to have in possession while you're in the city. Thank you.
No, and I find, Mae, there's certain pharmacies that are very familiar to working with people who use drugs and people that are on methadone, people who are on buprenorphine, and it does get tricky when someone goes to a region that it's not there. And it's not an excuse. I know that I really try to find certain pharmacies that are very comfortable and familiar with, and maybe that's where you come in, Mark, and maybe sharing some of your philosophy and your approach.
Yeah. Our profession's thrown under the bus here. I should probably speak. So no, I totally agree with you actually. And I wish I could defend my profession better. I certainly can't.
Well, we've not always done good things as physicians either.
I know, I get that. But certainly from my perspective,
on our table too.
The reason why we're so busy, and that sounds kind of self-fulfilling or a little bit egotistical, I don't know. We're so busy because the service is garbage, and I'm not afraid to say it. Especially among our Indigenous communities, I can tell you, Mae, passionately that I'm a humongous advocate for the respectful approach to complex mental health and substance misuse, especially among our Indigenous communities. Being from rural Labrador, I can certainly understand where you're coming from. I do work nationally with Indigenous groups in remote areas. I have got friends, family, and loved ones I work with on a daily basis at Blood Tribe in Alberta to across the prairies up to northern Ontario. So I understand where it is, and the flexibility in the model cannot just be with one substance. The flexibility has to be with the programming in general. I mean, there's not one substance that works for every person, one medicine that's great for all bodies. We're uniquely individual. And I think even the methadone guidelines are so dated. It's ridiculous. COVID, you're right. Nikki has taught us, we got to think outside the box. You know what? But not just regards to someone with opioid use disorder or prescription opioid use disorder. It's around employment standards. It's around labor laws. It's around a whole bunch of things where employers have to be, or people who have long employment. Like we have a 300,000 skilled workforce shortage in our construction sector, many of which we know have a substance misuse issue. How about we support those guys a little better by providing, a little more flexible dosing, dispensing modules, methadone, okay, long acting, dangerous, pure agonists. I get it. Works for some, not for others. It's still a great option. The mortality morbidity data is overwhelming on it. If it becomes the option of choice, we can't just have a directly observed therapy. The note about pharmacy and wanting daily dispensing because of fees, I can guarantee you, if any pharmacy is purely motivated by money when treating with someone with an opioid use disorder, their license should be taken, as far as I'm concerned. It is inappropriate, but unfortunately in medicine in Canada, where the first time where the business of medicine and medicine itself crosses is at the pharmacy. And it's a tightrope I've walked for many years as an independent pharmacy owner. We named our place Respect because it's the biggest thing missing from substance misuse in our country. So kind of our name and our mission statement on purpose, because we want to make sure that it's not there. Directly observed therapy may be wanted by some people who need it, who do not want to have access to it, Gary, because they're not stable enough for it. But the flexible model has to be peer-driven, person-focused. You know, health professionals have to take a step back in general, not just with this trial, but with other things, and start working for the clients rather than telling them what to do in appropriate ways. I know it's not as easy as I make it sound, but we gotta start treating people as people, not just, you know, as all the same. It's they're individual. Every program is different. But the fact and the most embarrassing aspect of my profession is if you have to give an urban-based Indigenous persons with a 14-day carry because they cannot be supported daily at a pharmacy is pathetic, as far as I'm concerned, and has to change. So where does it change? It changes with education and academia. It changes with professions. And maybe if you are going to be approved to be a methadone pharmacy, which I can't stand that term, or an addiction treatment focused pharmacy, you must be approved. You must be approved by a college of peers that says, yeah, you've got the right approach, buddy.
Just to build, Mark, off of that, and to give a shout out to our pharmacy colleagues, there's a pharmacy in Hamilton that has worked really, really hard to provide video witnessed dosing for patients, where they drive out to, they have a delivery pharmacist who goes out and does witness dosing, or they do like a FaceTime call or video call with the pharmacist when they deliver it. And it's made, for me, you know, a huge difference. And I know there's a couple of other Hamilton folks in the audience.
I know them.
A huge
They're
difference
awesome.
for those. Yeah, a huge difference in being able to provide that flexibility while also still providing you know, the safety of daily witness dosing, which is not to say that we shouldn't be thinking about ways to provide people with carries in more flexible ways. I think we absolutely need to do that. And also, I think there are ways that are outside of, okay, you must make it to the pharmacy each day, that can be really, really helpful for patients. And then the question is, how do we build a system that remunerates that type of work and doesn't remunerate other things? Like, I think of urine drug testing as another really important thing to address in flexibility. People have had terrible experiences of being video recorded while they pee every week for many, many years, and find that, you know, lots of people find it traumatizing, of course, and re-traumatizing for them. But the OHIP billing codes in Ontario, where I'm based, are such that there's a powerful incentive to see patients a certain number of times, to get them to do their urines, because of the billing fees associated with it. So there's certainly a need for an overhaul of how services are funded to promote models that actually work for patients, instead of models that are, frankly, like working for prescribers or for pharmacies.
Thank you, everyone. I want to just move us. Those were really interesting examples of flexibility. I want to move us, because there's been some questions in the chat, and lots of providers, some of them are scared to provide more flexible dosing. So I wonder if people can talk about any experience they have with possible risks or how they weigh those risks. And then just to answer the question in the chat, were overdoses tracked? Yes. In the OPTIMA trial, overdose was a serious adverse event, and there was no difference in serious adverse events among the treatment arms at the end of the study. So anyone comments about risks and benefits or approach to risk framework?
I was going to start, Nikki, if that's okay. And it kind of relates to Claire's comment about, you know, I mean, I work under the spirit of trust, right? I trust my patients until they break that trust, then I have to decide on something else. So you know, the spirit of trust is, so it makes me look at some of the ways that other providers provide their care. And as nurse practitioners, we can't bill OHIP, so we don't have that incentives. It would be interesting to see if we could bill OHIP if our practice would change, right? So I work directly for the communities that I work in, and billing codes, I think, is good incentive for compensating those who are actually doing the work. But I still don't understand videos for urine drug screens, like watching somebody pee. It's like, we don't even use urine drug screens in most of our programs because it doesn't tell us whether or not that person's going to be a good parent We've had lots of children taken away and put in care, and they're rebuilding their lives. So that trust is so important. In our programs, we have over 95% retention. Some of them is 100%, because they don't have nowhere to go. They're in their home communities. Again, some of them are really big, like, Sandy Lake has, 3,000 people. Some of these communities, 300 people. So they're seen every day by somebody in that community. They know when they relapse, they know when they need to go for other care. So when you look at trauma-based care, which is what we're doing in these northern remote communities, we're focusing on the unkind Canadian history and the impacts on our generations. We're still in the middle of suicide crisis. We've had lots of overdoses during the pandemic. So for us to provide the best care, and again, we have our own practice standards. We call them, practice-based evidence. And if you've worked up north, you know what that means. You use the people who are there to help you do the work that you have to do, because it's pretty overwhelming. But I think in some ways, yeah, the spirit of trust needs to be really, come up through the ranks. And there's lots of new people who want to do this work, and they're appropriate for it. And I think we should really encourage them and not hold them back by certain models and rules. So thank you.
Thanks so much. Anyone else comment on risks?
Your question was around how do you reduce people's fears when they become flexible in their prescribing? And I know for myself, just knowing what's done where it comes from helps me a lot. So knowing that in New York, they've been giving weekly supplies of buprenorphine right from the get-go, knowing that the Ontario one was done just based on transposing the methadone ones. Historically, when I felt it's indicated, I would say I'm using, I'd have to tell the pharmacist, this is like 7-8 years ago, I'm using it off-label for pain. I would have a rationale for that. If you look at where the SROM and the methadone starting together came from, it came from the Saskatchewan guidelines, right? So there's no evidence or data or studies on it, but it was practiced there. And so then you can sort of bring it here. And by knowing all these different philosophies, you can almost apply it. And then I try to have 2-3 colleagues that I can text or reach out to. Sometimes I will reach out to the Medify forum, but if I'm nervous that people are going to be upset that I'm being too liberal or whatever, too conservative, I might reach out to a smaller group. I don't want to be attacked when you're trying to do the best. I mean, I've had patients that have passed away from diverted methadone where they weren't even being prescribed methadone, but maybe they're on opiates for pain. And I've had other, it doesn't matter whether you do something or you don't do something, there's a small subset that are going to be harmed by that approach. And so it just has to be really personal. It has to be really about that connection. And the more that you know about where stuff comes from, you realize it's not really based on data. Like it's not, a lot of these guidelines are pretty, a lot of times they're consensus based. They're sometimes they feel arbitrary, and they may not apply to the patient that you're working with in the environment that you're working in. I mean, we can all agree that if somebody can work full time and get their methadone in a safe way, their lives are going to be better, rather than not being able to work because they have to show up at 10 o'clock because that's the only pharmacy in the area that they can get it from. So I just think, I think there's a lot that we do out of fear, and justifiably so. I know people that did 1 or 2 things where they did like a visit on OTN, and then they had that on their CPSO statement for years, right? That they did an OTN visit for methadone. So the consequences are real. And I think that's why a lot of the pharmacists haven't come along well for some of the more flexible models. And it makes me wonder about Lori's comment around, is there any sort of initiative to help pharmacies become more flexible without fearing some of the repercussions, and I don't know what the answer is. I just, I think some of these rules and regulations are arbitrarily punitive, and it's almost a barrier for some people to get care and treatment, right? So just a couple of thoughts, I mean, even when I think back to when I trained, right? So no methadone doc would prescribe benzos, even though they were the best person to do it, in my opinion, rather than a family doctor giving a month's supply, because once you start to get audited, you get destroyed, right? And in fairness, people are dying. And for me, I was able to avoid it because I worked in a hospital setting, and I only had a small number of methadone patients. And when I saw them, I only saw them for that transition period. So just thoughts, ideas. I know everyone's listening. I see a couple of comments in the chat as well. And so I think, Mark, you inspired me to just share a little bit of a raw opinion, right? As opposed to being overly polite, So, but I'm not at your level yet. It's not that raw authenticity because it's going to be recorded on YouTube, and I don't want to lose my license.
Well, it's the interesting part about the license. You don't want to lose your license, that, and that's probably where it speaks from. It's the fear of impending consequence for behavior that's completely apathetic and appropriate, well documented. Like, I know I'm having a hard time. It's interesting. Pharmacists act out of fear all the time. They don't want to extend. They know someone's going to use a street opioid. They've seen it. They know. If they get a little story about why they use the opioid in the first place, like by stopping an opioid dispensing, even if you don't have a refill, okay, or is not going to prevent the person from using an opioid in acute withdrawal. I don't know what you're telling them. It's interesting that they actually, the pharmacists think that it's, and that's where it stems from. They think that by preventing access, you are going to stop them from using the opioid. And which is the silliest thing if I've ever seen in my life. So I think if you really get a picture and maybe more education with the new younger pharmacists, re-educating our practicing pharmacists now around why they use the opioid, how they can't live without it, what it's used for, it's a mental health disorder. I think you're going to have a little bit different opinion by providing a safer alternative, which is really where the safer supply program came from, may actually be in the benefit of the patient until they get stabilized, see a physician, extensions, more flexible models, and so forth.
Well, doctors were just as bad, right? So, when you found out a patient was diverting or abusing back 10, 15 years ago, you stopped prescribing. And then eventually they realized that was unethical, so you stopped prescribing, that you see them later, right? It's only recently people are saying, hey, assess and treat both the pain and the withdrawal and the problematic use, right? And so it was safe for them because we don't think about the harms of not giving something. Right, we're just wired that way in medicine, and as we start to add that, what's the harm of not giving this? Like, I think it can shift. It's much better to take somebody on 100 of methadone, they miss a few days, drop them down to 90 or 80, than to just not continue the script. It's devastating for them. Claire, you were going to say something, and I interrupted.
No, it's all good. It's an interesting conversation. So I'm a new grad, right? New prescriber. I'm in my second year of practice, and so in some ways, it's a blessing because I don't have the like fear from the previous audits. It's not as palpable for me. Like, I've heard stories, but it hasn't been the same situation to sort of start as a prescriber in. I do think one thing that can be helpful for flexibility is to move away from this very individual approach to care, which is a really Western medical model of, I'm the individual prescriber, and if I make a mistake, it's my fault that something happens to the patient. I'm an individual pharmacist. If I dispense this, it's my fault that something happens to the patient. And I'm working with this sort of like isolated, rational individual, which is really how I think a lot of our Western medical training is framed and systems, and shifting as much as we can towards thinking about people as living in a community, and we're all a part of that community, and we have shared responsibility for each other. And I think that's one of the big lessons we can take from the Northern programs is that, people are understood as being a part of a community, whether that's like, working in the treatment program, dispensing the medications, whether that's being the prescriber, whether that's being the patient. There's these mutual relationships, and then that trust that people are able to have with each other as sort of a given, and then repair if it gets damaged. And where I think I see that coming into my like urban practice is that I work as part of a team that includes a program manager who's a person with lots of lived experience of substance use and other things that a lot of my patients are dealing with, like homelessness and that sort of thing. So her perspective is really helpful for like holding the prescribers accountable to the decisions we're making and shifting them. We have a patient advisory group that also helps to shape like our program-wide practices, because we recognize when we prescribe to an individual, the impacts are not just on that individual, they're on, the community of people. And then Whip, your comment about having trusted colleagues, like that's my go-to move when I have somebody where I'm like, I really think that they would benefit from doing something different than my usual practice or different than sort of the guidelines. I think through it, and then I talk to those trusted colleagues, and they're a good balance for me to say, yeah, okay, that makes sense. No, maybe we'll shift that. And it does take work. I think of a patient of mine who had her full methadone carries, but she was living in a shelter or like a transitional housing program. So they were holding her medication and giving it to her each day. So even though she had like earned her carries and been stable for a while, she had never self-managed that medication in the same way. And she was going to visit her grandmother in rural Alberta for like an extended period of time. So we had to figure out like, okay, we're going to get you a safe You're going to check in by phone twice a week. We'll find the pharmacy that will be able to have you in. She was open to us talking to one of her family members who was also going to be sort of a like accountability check-in person for her while she was there. So it does take work, and I think we can get creative. We can put in that time and effort together to again take a more community approach to supporting someone's health rather than just this like very individual approach.
Thank you. Those were really interesting, and I know there's a lot of fear, but from my perspective, which granted is the academic OAT provider perspective, like there are not guidelines in Ontario that would prevent flexible dosing. Like at this point, the CPSO has said you practice like within how you're trained, especially if you consult colleagues. I don't think that providers need to be scared about practicing in a way that's reflective in this trial, for example, or in the way that any of the providers here have discussed. I think that it's maybe there's some trauma related to the past CPSO involvement, as Whip was saying, but I don't think we need that fear right now. So I want to move now. We are just trying to keep us on schedule. I think we talked about the changes with the pandemic. So I want to move now to maybe what's next. What's next for expanding flexibility to other areas of OUD care, and how can we propel these changes? So maybe we could start with what's the role of nurses, for example, in expanding flexibility? Any thoughts on that?
So I guess I'm the only nurse on the panel. So as a nurse practitioner, I'm doing that. There's some very interesting things that we're doing. And I went for training last summer, I guess, with a physician to do Sublocade injections. I've been a nurse for 40 years, but I still had to go learn how to give these injections, right? It was to become a trainer, to train other nurses. And our communities are asking for two things. One is an exit strategy to come off Suboxone, and Sublocade is a very, it's working in one of the communities that Dr. Sharon Cerrone is working in. So the exit strategy is after 4 or 5 months on Sublocade, you just don't go back for your next injection. So there's been a lot of support within non-insured health benefits who pays for Sublocade, as well as for, the nurses are now the ones who are being asked to do this. So changing to a different formulation of the same medication, buprenorphine, is one of the things that we want to do. But it'll also take people off the list. So, where there's 200 or 300 people on a Suboxone program, we can take them and move them over to Sublocade and then allow more people to come on. During the pandemic, we've had a number of people requesting OAT, and one of the reasons why is the dealers weren't able to get into the communities because of the lockdowns for the last 3 years. So drugs became very scarce, but they still had the craving for opioids because they had the opioid addiction. So low dose worked very well to support them. And I think for our next so the next focus is Sublocade with land-based healing programs. And we have a number of those who are starting up. We did a national policy work during the pandemic with Carol Hopkins, and we have a sort of high-level policy paper on the how successful land-based treatment can be to deal with the trauma. Thank you.
Thanks so much.
One thing, and I get maybe this is more like what we're doing, but it might be a thing that is helpful for other folks. So we pay, I want to say $30 a month for a phone system called TalkRoot. And basically what it allows is for patients to text the on-call number or call in to the on-call number. And we have a doctor on each week. We answer at 8 a.m. to 8 p.m., but we don't answer it immediately. We say, like, listen, leave a voicemail. We'll get back to you within an hour or two, kind of thing. There's no remuneration for it, but there is obviously billing if you're doing a phone assessment. But it has been huge for patients who like miss appointments, for patients who, you know, the secure chat messaging things that are available through EMRs are just not something that they're going to be able to download. They need just like a regular SMS situation. For people coming out of prison or jail who know that they can call an on-call doctor and get their dose restarted that day. So I would strongly encourage as like a pretty low cost way of expanding flexibility for patients. You know, it's certainly been something that's worked, I think, quite well for our patient group, and it's toll free, so people can call from like a payphone or a 1-800 number. We work with a lot of people that are deprived of housing, so that's been important.
Amazing, so interesting. Whip, you were going to say something.
I was just going to say, really admire both what Mae and Claire, what you've been sharing that you're doing in the local communities. It's not enough to wait for the system to create something, and sometimes people have to figure out solutions that work. And it's just really, yeah, just thank you for sharing. And it makes me wonder what solutions I need to figure out here, right? As opposed to waiting for something else to happen.
Mark, do you want to comment on ways forward for pharmacists?
Yeah, I mean, besides the education and the things that I mentioned earlier with new young grads and practicing pharmacists, I think we need to really, I guess, embrace technology, embrace you know, the restraints on facility, on hours. So, you know, physicians need to be remunerated for after hours care. I see that on the chat there. You're 100% right. You know, how long I've been trying to fight for my dream is actually for nurse practitioners, I love you all, is a mobile outreach nurse practitioner team that can work in conjunction with us as the pharmacy, but also access to physicians after hours, because pharmacies are open late, right? We're open 7 days a week. We haven't closed one day since I opened our practice in October 2013 for the construction sector, for everybody else. But ultimately, if we're going to be open, and, you know, that speaks to people's substance use, right? And, you know, it's very individual. So we're going to be open late, whether it ever be a 24-hour situation, whether it ever be like that, then we need access to physicians at times. So, you know, I don't expect you just to roll in the pharmacy when I give you a call. Can you drop down and see a patient? What I'm expecting actually, though, is using our technology, whether it be a chat-based system, WhatsApp that's secure, access to parts of EMRs that are linked to clinics that you are partnered with, that are, you know, restrictive, but yet we can see urine drug screen samples. We can see next scripts potential. We can see next appointment dates to communicate with men, you know, withdrawal management protocols, standing orders. I mean, there's ways and procedures with a really open-minded community pharmacist that you guys can, you know, advocate with. And I think, again, I guess is taking the health team approach that works for community health centers in different regions, applying it to complete outpatient in a, you know, private practice. The other thing that really makes sense and what the government really has to get behind is that private public partnerships work. So whether it's be private, you know, for some reason in this whole industry, in health in general, profit is a dirty word, but profit motivates individuals to care for their clients. I'm not saying you're looking for money, but in an appropriate way where 80% gets back, a capitation model, whatever. But I'm looking forward to exploring options with community-based pharmacies that are really good for retail operators to apply it to some of the practices and principles of this trial, to expand practices for OAT in a more comprehensive, flexible model. And it can be done through education, technology, and communication.
Thank you so much. So we're nearing the end of our webinar. I just want to give a last 2 minutes if there are any resources that our panelists want to tell members about so that they can learn more about flexible models of care. I invite you to share them now.
So we created a lot of literature in the early part of the program that we were rolling out to our communities. One was on adolescence, and Dr. Mae Katt is one of the authors on it. And so we were the first high school to open up a Suboxone program on site. And between classes, the students came and got their Suboxone from the nurse's clinic. And we had 43% of our high school actually addicted to OxyContin in 2011, and that's how we started. So what we ended up doing is putting the flexibility in the high school. We were a private high school. I don't think any of the public high schools would ever allow this. But because of, again, the need that we had, within 5 years, we'd actually cleaned up the high school where we didn't need the Suboxone program anymore. But it wasn't just because of the work that we did in the high school. It was the work that we did in the home communities where these kids came from. And so we treated their parents. And so we didn't see other generations becoming addicted to the opioid. So that was, one of the highlights, I think. So there is a lot of literature. Dr. Sharon Cerrone, again, did the one project on a treatment and then a post-treatment indicators of what success is. And now she's going to venture in on her Sublocade project and look at how that rolls out. And we all know in Canada, if you don't publish it, then you didn't do it, right? So we are publishing as much as we can. So thank you.
Yeah, I just think for all of you that are involved in this, finding some kind of a community, it could be local, it could be reaching out. Medify has a listserv that's there. CAMH ECHO has some addiction kind of a basic training. We need the generalists to take on some of these practices as well as a society, and we're not going to be able to do it without having colleagues and stuff around us. It's hard to do it on an island alone. And so for those of you that have chosen to come here, I hope you're able to find some kind of community to help you figure out how to best serve. One of the saddest things about working in substance use is that, usually when people come up bright-eyed like Claire, when you graduated, they only last for a few years and they move on to something else, whether it's more administrative or another field and so forth. So people like Claire, Mark, and Mae are more the exception than the norm. And if all of you are able to find a couple of people to connect with, I think the Medify is a reasonable way to start. I think the Ontario College of Family Physicians has some community practices and stuff as well. We need people that are willing to serve the most vulnerable, and a lot of it ends up being under more unpaid and stuff like that. So that's all. Those are my thoughts. Thank you.
I think my final, can I say one last thing? Is that okay, Nikki? Okay, I'm going to take that as a yes. I think the thing that I would hope to impress upon people, and I know that I think everybody here probably knows this, but like so many people are dying, and well before that, so many people have lives that are incredibly disrupted, whether it's by like infections or by breakdown in relationships or by whatever. And we need to move away from a perspective of being really rigid because it's what makes us feel comfortable, towards a place of being flexible, recognizing that there are going to be risks in everything that we do. And what we can do is manage those risks, talk about them with patients, make a plan together, try to put in as many sort of other supports as possible. But that it's not acceptable or defensible anymore to stay really rigid when the stakes are so high for people and communities.
Thank you so much. There were a few questions that haven't been answered. One question was around the breakdown of the ages in OPTIMA. So to my knowledge, there has not been a sensitivity analysis to this point looking at transition age youth. I expect that the numbers were just too small in that age group. But we can circle back to the study group to see if they're planning any secondary analyses on that question. What other questions? Other people asked if there have been any provincial level conversations regarding changing payment models for OAT. I don't know if anyone wants to field that question.
So as nurse practitioners, again, I belong to Registered Nursing Association of Ontario, and we've been pushing for Ministry of Health to, acknowledge, I think, the work that nurse practitioners do. They keep expanding our scope of practice, but they don't increase any compensation models so that we can work on a team or in places where other people don't want to be right now. So again, one of our more serious barriers, I think, is the Ontario Medical Association. I know some of you are doctors, but again, their view is it's a pot of money that's meant for physicians. And we're saying we're not physicians, but we do have some authorities that's like yours. And one is the prescribing of controlled drugs. And so to be able to do the work that I do with the patients that I see, I need to have a compensation model. I do lots of free work. And that's okay, because as you said, people are dying and people's lives are disrupted. And I will do that again, you know, to me as an end of career nurse. I mean, I'm not looking for the payment, right? I'm looking to help people and try and save their lives. So I think in some ways we need to look at removing those barriers, and we need our colleagues to come and support us. There's only 4,000 nurse practitioners in Ontario, but we'd love to be supported more, I think, in the work that we do in the field of mental health and substance use. Thank you.
Thank you so much. Anyone else have comments about provincial discussions?
I have to say, Mae, the fact that nurse practitioners cannot bill for your services directly to the Minister of Health is absolutely ridiculous. Oh my, it's so silly. I don't get it. I never will get it. I will never understand it. They gave us prescribing rights right now. We can do things like small amount prescribing. I've got an order here for some hemorrhoid cream as an example. Like, it's ridiculous. I mean, I'm getting reimbursed for this. I have a hard time understanding, you know. I do believe our system is a little broken. So anything we can team together to realize that, you know what, we're not saying we're doing someone else's job. No, we recognize, especially among family physicians, the hardest job in medicine, as far as I'm concerned, is there's not enough of you guys. Your remuneration model is terrible. We're losing family physicians, as an example, who could do a lot of this work at the beginning, out to other jurisdictions because of it. And until we actually support family physicians, nurse practitioners, community pharmacists in a more of a collaborative approach, it isn't going to make a difference. And whether it's private, public, whether it's some other model, you're all 100% agree. I think that, you know, we don't have enough health professionals for every situation right now. But we have to do something like Claire said, because it's clearly evident that it's not working. We skyrocket to almost 3,000 deaths in Ontario this year, like almost 8,000 in Canada. Are you kidding me? 43,000 since 2016. So obviously it's bigger, it's a larger issue than COVID. Let's face it that way, right? So let's do something about it.
Thank you so much. I just want to recognize that our time is ending. So if anyone needs to jump off, we totally understand. The panelists will stick around for another 5 minutes to answer any questions that are remaining and to chat.
I was just going to say, for the funding models might overlap with what you were going to say, Claire. I mean, I'm not at the tables where the OMA addiction medicine is discussing, so I'm not sure about that. I don't think it's the physician remuneration. It's that model for those complex patients that need that wraparound care that's there. And I think that's where some of the challenges are, right? Mm-hmm. And so it's when all that extra work comes in. But I don't know if that's
I was just going to say, I mean, I think in Ontario, the move right now is to get yourself involved with the Ontario health teams, right? Like, that we know is the direction that the government has indicated that they're headed in. And I think that one of the limitations of the Ontario health teams is that the ones that have been most successful generally are the ones that are already like big institutions. So you have hospitals at the table, you have, you know, your large family health teams. And so finding a way for the frankly, like, smaller potatoes of us who are doing work with people who use drugs to get us at those tables and be a part of shaping the Ontario health teams, I think is an important strategy, because the conversations there are that, you know, mental health and addictions is a priority, and team-based care is what every Ontarian should be able to access. So I do think that's a place that's worth us collectively trying to be a part of.
It's tough because it's these smaller clinics that really serve these patients for the last 2 decades. It's not the large institutions, you know, they've not had all those services, and you've had these independent practitioners that are trying to catch everyone falling through the cracks, or whatever the metaphor is. So yeah, it's too bad that that's the case. I did want to just say, because I love the Medify forum. So if I said anything critical, I mean, that's how I learned about addiction medicine and pain medicine. I would send a text there. I'd get 4 different responses how to answer. And so I just would hate, it's just this online community practice that some of you might know about. And it's a great way to pick up the addiction skills when you're out in practice. So I just thought I'd throw that out for an Ontario thing, because there was a comment there that people were sad that I had negative things to say. I don't have negative things to say about that. So more about capacity building than about flexibilities.
Oh, thanks everyone. If there's any other questions, we'd be happy to take them now. Otherwise, I think we will wrap up.
Thanks for hosting, Nikki, and for having us.
Okay. I want to thank you guys all for joining. This was really interesting, and I hope we can continue the conversation. Remember to fill out the evaluation.
Yeah, nice to be on a panel. Mark, Claire, Whip, good to see you all. Maybe our paths will cross again.
Totally, May. Hopefully I'll see you up north sometime.
Oh, that
Yeah,
sounds
definitely
good.
hope so.
Thank you.
Thanks for everyone does to help fight the crisis, because without guys like you, people like us, we don't know what could happen. And I know at times as health professionals, guys, you know, we see the negativity backwards, but you know what? We don't ever often report the positive stories enough. And that's important to remember that too, because our clients also feed off the positivity. And I think we need to get away from the negativity that's reported every single day and start reporting some of our positivity.